Right. Good afternoon or good morning, everyone. My name is Bethany Hamilton, Director of the National Center for Medical Legal Partnership based at the George Washington University. As folks are logging in, just going to begin to open up our national audience webinar today, provide some housekeeping, introductions, and then kick it over to our subject matter experts who are MLP practitioners from the field here to talk about what they know best, how to practice and implement medical legal partnership. So welcome. Today's May 23rd, 2024, 1 p.m. Eastern Time. You are joining us on our Health Center MLP Planning Implementation or MLP PIP webinar series. This webinar series is a national audience activity, so we welcome and invite folks from across all sectors to join us. And especially for today's webinar, that becomes important because we are highlighting and exploring some of those distinctions as well as similarities in both health center or community health centers, FQHCs, for example, and hospital-based medical legal partnerships. We are very happy to have, MLP practitioners from the Georgia Legal Services Program with us to share their insights as they carry out medical legal partnerships across both types of healthcare settings. So welcome, everyone. This webinar is supported by the Health Resources and Services Administration, or HRSA. The National Center is in its 10th year as a cooperative agreement partner to HRSA, providing trainings and resources to the health center community and others to better understand how to implement and leverage MLP strategies to better reach patient populations and their holistic care needs. However, what we share out today does not necessarily represent the official views or an endorsement by HRSA, HHS, or the U.S. government. All right, housekeeping. As you know, we've joined via Zoom, and so we encourage you, as this is an intentionally interactive webinar series, to utilize the Q&A. Also, feel free to use the chat, and at certain points, we will actually ask people to use the raise hand feature in Zoom so that we can unmute you and hear from you. The flow of today's webinar will be pretty heavy on the presentation at the beginning, and then we'll open up for ample Q&A. And at that point, we'll use this raise hand unmute feature to hear directly from you. So we encourage you to use all of the methods in Zoom to interact. I'm just going to scroll back for a moment to note that yes, to answer your question in advance, this webinar will be recorded. And if you sign up for the MLP update, you'll find out when the recording is available, but also you can bookmark our medicallegalpartnership.org resources page to keep track of all of the past and upcoming webinars as a part of this series. Okay, so as you can see on the screen, this is actually a co-hosted event. We're partnering with Texas A&M Institute for Healthcare Access. The faculty joining us is Keegan Warren, the Executive Director of the Institute for Healthcare Access, and Jay Sicklick, who's actually faculty at UConn. Both of them are not on today because I will be your moderator, but we have co-designed this entire series to ensure that we are meeting your needs in terms of better understanding the mechanics of MLP and how to apply it, and perhaps also improve upon your existing well-established medical legal partnerships. I want to continue to thank Jay and Keegan for supporting us on this webinar series. And also our NCMLP colleague, Reha Manakandasamy, who's our data scientist on the team. She is online, and if you need any assistance, feel free to DM her if you need help during the webinar, or overall through the entire series. Feel free to contact her by reaching out to our general ncmlp@gwu.edu inbox. We're here to help. So that's the faculty, but let's find out who's joining us here today. To help us facilitate knowing who's in the audience, we're going to run a poll. So Reha, may I bother you to launch that poll? Let's find out who's joining us here today. So let us know. First poll question is, are you from healthcare, legal services, academia, or other? Second question helps us find out what type of, if you are currently as an organization operating in MLP. If you don't know, that's okay. Let us know. Maybe you're not sure. And the third and final question helps us better understand if you do have an MLP, who are some of the partners that you're working with? Are you working with an FQHC or a community health center? Are you working with a hospital, an academic medical center, a law school, legal aid organization? Perhaps you're partnering with some pro bono attorneys at private law firms, or maybe there's other. For the folks beginning to answer other, take a moment to let us know who the other partners are in the chat. It's going to be particularly helpful and important during today's webinar as the Georgia Legal Services program team presents. All right, so we have about 85% participation, and we've closed out the poll, sharing the results. Great to see that we have healthcare folks joining us today, legal services as expected. Welcome back. The large majority of you have MLPs, which we greatly appreciate having folks here who have established MLPs because we always believe in continued learning and would love to hear from you all more about how the subject matter experts are aligning with or may differ from what you currently engage in your practices. Welcome to those who do not currently have an MLP. Let us know how we can continue to move you along your MLP journey to implementing one. And then for those who don't know, let us know, reach out, we can assist you. About half of you are from health centers. Thank you, thank you, thank you. And another half from hospitals. That's very interesting. Excuse me, 48% of respondents from FQHCs, 48% partnering with hospitals. And then a mix of legal aid, academic medical centers, law schools, and other. All right, so we're going to stop sharing. It's great to know who's joining us today, and we will do our best to tailor any potential remarks that may come in through the chat and Q&A according to where you're from. So again, you're joining us on our webinar series that we're partnering with Texas A&M Institute for Healthcare Access on. This webinar series is designed to run with our Health Center MLP Toolkit, which you do believe, because of the way it was designed and who informed it, that it's applicable to MLPs across settings. So go ahead and utilize that resource as we continue to travel through the series and you're implementing your MLP practices. And then engage with us. This is an active learning series. Here's where we've been so far as we travel through the toolkit. You'll see that we've talked about what SPH problems do we want to address, and then how do you staff the MLP to accomplish your goals? How do you also build out that partnerships with the legal services? So do you want to directly hire an attorney, or do you want to contract with another organization? And of course, we know the big question that always comes up is how do you pay for it? But as Jay and Keegan presented, it's really important and crucial to think about your budget, a really comprehensive budget so that you can pay for costs and expenses that come up now as well as down the road. And how do you develop that strong MOU? We covered that in the last webinar. As we were designing and thinking about how to design a sixth webinar, what other partners in the community can be helpful, we started to think about how to incorporate MLP practitioners from the field that will help to illustrate how you move from theory to practice. And so that's where we looked to the folks from Georgia Legal Services who are actively planning, implementing, and practicing a diverse set of medical legal partnerships that they'll talk about today. So I'm very happy to introduce you to that Georgia Legal Services team. So we are joined by Ira Foster, Georgia Legal Services Program's General Counsel. He's also founder and creator of the Atrium Health Navicent hospital-based MLP in Macon, Georgia, and co-founder of the McKinney Medical Center, which is an FQHC-based MLP in Waycross. We're also joined by Rachel Henderson, who's GLSP's specialist attorney, and also a co-founder of the McKinney Medical Center FQHC-based MLP in Waycross. And we're joined by the two MLP attorneys who are running the show at each of these health center and hospital-based MLPs. First, GLSP MLP attorney Tara McIntosh, who's based at the Atrium Health Navicent hospital-based MLP in Macon. And last but not least, Malik Hines, who is the GLSP MLP attorney at McKinney Medical Center, again, that FQHC-based medical legal partnership in Waycross, Georgia. Thank you so much, Ira, Rachel, Tara, and Malik for joining us today and sharing some insights with the rest of the medical legal partnership field about your experiences in running and starting and continuing to improve upon a hospital and health center-based MLP. Before I turn things over to the GLSP team, just want to make sure the audience knows today what are our learning objectives, and then I will quickly highlight some key aspects of considering the various community partners in the community that you can work with in your communities. So here are our learning objectives. First, we're hoping that you'll walk away with general information again about MLPs and their formation. Number two, we want to discuss how relationships with various community power brokers can impact your MLP. We're hoping that we can also help you explore the differences between those hospital-based MLPs and health center-based MLPs, as well as what are the similarities. And then finally, we're hoping that through the GLSP team, especially, you can hear their insights from them as attorneys about how to facilitate that groundwork development that's necessary for your MLP. So the practice of MLP. All right, so as noted, let's talk about very quickly the landscape of community partners. Just want to lay it out and encourage people to take a look at the chat and get ready to engage. When you're thinking about medical legal partnerships in the community, it's not just about who's your healthcare partner and who's your legal services partner. There are several influential groups or people or stakeholders in the community that very well may have an impact on how fast or how far your medical legal partnership goals move and can be achieved. So you can see that we've highlighted on the screen some of those potential partners that you can think about working with in terms of socializing MLP with them as stakeholders, or even utilizing what power they have in the community to help you achieve your goals. Policymakers, for example, client and patient advocacy groups, you have trade and professional associations, this is primary care association, the Access to Justice Commission, or bar associations, you have accountable communities of care organizations that work with healthcare, various healthcare partners in certain communities or states. And then of course your state Medicaid agencies. Take a moment in the chat and let me know. I just want to see if a couple of folks can use the chat to help highlight maybe two more examples of potential partners in the community. So we have someone in the chat, Christina Walters, suggesting that in addition to health centers, we have a partnership with a comprehensive homeless day service center. It's a great example, Christina. I really appreciate you sharing that. Anyone want to share another? Remember, we're an interactive group here. Take a moment. What are we missing on the screen in terms of community partners? Academic institution, great suggestion. And that can be both at the higher ed, university level. Greatly appreciate Anthony De Benedetto. Hopefully I got that right, Anthony. But we can talk about how you can partner with academic institutions, such as at the university level. Perhaps it's your law school or academic medical center. Maybe it's a school of public health. They can conduct evaluations, or maybe you're even thinking about K through 12 and partnering with, for example, a school-based health center to ensure that you're expanding your MLP services to youth. So great suggestions. Let's just move to the next slide and make sure folks understand. Yes, as you can see, we were thinking exactly as Anthony was thinking. For example, academic institutions are key. You also have folks who are based at health center controlled networks that you may want to leverage. And don't forget the role of courts. There are courts around the country who are really thinking about working better, more efficiently and effectively to serve clients and indigent defense clients who are coming through their doors, and ensuring that they're playing their role as a part of the justice system to ensure that holistic care, holistic justice is being carried out in communities. So don't forget partners like courts. All right, and then Medicaid managed care organizations are increasingly engaging as partners in communities that MLPs can engage in. All right, so I want to highlight this, and I don't want to steal any thunder, but maybe you are in a community where it's not necessarily as resource rich, or maybe you're like our GLSP team, where you're serving the large majority of counties in the state of Georgia, and you don't have a lot of attorneys, and you have to figure out how you're going to be able to close that justice gap and increase access to care for rural residents, folks who are really hard to reach and facing so many of the barriers that we talk about in the social determinants of health field. Is it possible to build medical legal partnerships, as you can see on the screen, outside of the Metro Atlanta area? I'm just going to let you all know yes, and then pass it along to the experts to tell you how. With that, it is my pleasure to hand it over first to Ira Foster of Georgia Legal Services Program. Georgia, Ira from Georgia, all yours.
Okay, thank you, Bethany. Thank you for that introduction, everyone. As Bethany stated, I am Ira Foster. I'm the General Counsel with Georgia Legal Services Program, and I want to thank Bethany and the staff at the National Center for allowing Georgia Legal Services Program to participate in this workshop and to share with the attendees what we're doing with the two medical legal partnerships that we have in Georgia. Next slide, Bethany. I want to, next slide. Okay, thank you. What I want to do now is give the attendees a brief overview of Georgia Legal Services Program. Georgia Legal Services Program is a legal services grantee program. We provide services, civil services, to low-income individuals and individuals over 60 years of age in 154 counties in Georgia. Georgia Legal Services Program was established in 1971 by the Younger Lawyers Division of the State Bar of Georgia. We have 10 offices strategically located all over Georgia to provide services to our clients. We have 200 staff members, and of that 200 staff members, about 93 are attorneys. Next slide, please. Now I want to talk with you briefly and give you an overview of the two medical legal partnerships that we have. Again, we have two medical legal partnerships. One is a hospital-based model, and one is a community health center model. The first medical legal partnership that we established in 2016 in Macon, Georgia. We partnered with Atrium Navicent Medical Center to start that medical legal partnership. When we started that partnership, the MLP was initially funded by the foundation. The foundation, they have a pretty big budget, and so they were able to provide funding for the medical legal partnership when we initially started in 2016. The partnership, it grew and developed, and it's working quite well, and now every year we're listed as a line item in the hospital's funding budget. The cases that we focus on are the cases that are listed as the IHELP acronym as related to medical legal partnerships, income maintenance type cases, health cases, education cases, landlord tenant cases, and public benefit type cases. Again, the IHELP model is the acronym that's used to describe the services that most medical legal partnerships provide. And again, one highlight that I want to mention about the Atrium Medical Legal Partnership is that it's located in one of the largest cities in the state of Georgia. So when you're considering medical legal partnership, if you're in a metropolitan area, partnering with a hospital may be a better model than in rural areas. Next slide, please. McKinney. McKinney is the second medical legal partnership that Georgia Legal Services started. We established McKinney in 2022. Myself and Rachel Henderson, who you will hear from shortly, she and I worked together to establish that medical legal partnership. Our partner with the McKinney Medical Legal Partnership is McKinney Health Center, which was established in 1995 as a federal qualified health center. Initially, when we started the medical legal partnership, McKinney used discretionary funding for a year to fund the project. Now we are a part of their yearly budget. As far as the cases that we serve, again, we use the IHELP model, income maintenance, health, education, landlord tenant, public benefits type cases for the clients that we serve in McKinney. One thing I want to highlight regarding McKinney is the comparison contrast between McKinney and the Navicent Atrium model. Again, as I mentioned earlier, the Navicent model is located in one of the largest cities in the state of Georgia. McKinney, on the other hand, is located in rural South Georgia. McKinney is located again in Waycross, Georgia. Waycross, Georgia is located on the border in South Georgia, near the Georgia-Florida border. It's very rural. The county has about 13,000 people. 17% of the population lacks health insurance, and 24% of the residents fall below the poverty line. So the McKinney Medical Center partnership, it's a good fit for Georgia Legal Services Program because, as you can see, with 17% of the population lacking health insurance and about 24% of the residents falling below the poverty line, a large percentage of the clientele that we see at McKinney will be, they'll have similar issues. Their health issues will be similar to the clients that we see that have legal issues. So again, McKinney is a really good fit. Next slide, please. Now, what I want to do is for the individuals that are on the line today that are participating, if you do not have a medical legal partnership, I want to highlight 10 things to consider if you are planning to start a medical legal partnership. And then for the large majority of participants today, from the survey that do have medical legal partnerships, hopefully some of my tips may help, build your your medical legal partnership a little stronger. Maybe some of the pointers that I will highlight will help in your development and growth of your medical legal partnership. But primarily my tips will be geared toward those individuals that are on the seminar today, that are joining this webinar, if you are considering starting a medical legal partnership. So next slide, please. Number one, if you are thinking about starting a medical legal partnership, the first step is to decide the best model, the best fit that will be for your organization. Again, there are two type medical legal partnerships. There's the hospital model, and there's the federally qualified health center model. You need to look at your demographics. Quite honestly, quite frankly, if you're in a rural area, the health center model may be better because, again, under the hospital model, the hospital generally provides the funding to support the medical center, but in small rural areas, you're not going to generally have hospitals like the one in Macon that has a large foundation that helps support our medical center with Navicent Atrium when we first started. So if you're in a rural setting, the community-based medical center may be better. And if you're in a metropolitan city area, the hospital model may be the better. Next slide, please. And second step, when you're considering starting a medical legal partnership, is you have to identify the key players. You have to identify individuals within the community that will help you work with the hospital or health center to help you get your foot in the door, so to speak, to get those folks that are at the hospital or the medical center to listen to you, to hear your overview of the plan of how you want to establish the medical legal partnership. Ms. Henderson, who's coming up next, she will talk with you about the importance of establishing key contacts. And two things I want to mention about contacts is with the medical legal partnership that we started in Macon, Georgia at the hospital, we had contacts there because when we initially planned to start it, I worked with the attorney for the hospital. She and I were a part of the Macon Bar Association. I was the president at the time, and I appointed her to a committee. And so through my appointment of her to the committee, she and I, we began to work together on the medical legal partnership. And with the medical legal partnership in Waycross, Georgia, again, Rachel Henderson had a great relationship and still has a great relationship with the director for the medical center. And so that was a big help in, again, allowing us to be able to sit down and talk with the director at the health center about the medical legal partnership. Next slide, please. Tip number three, point number three, identify and decide the defined patient population that you want to serve as you embark to develop a medical legal partnership. One of the most important things you should consider is, who will be the clientele that will be served by this project. Look at your community. Again, if you're in a rural setting like McKinney, there will be low-income individuals that attend the health center. That will be your client population. And then at Navicent Atrium, which again is located in a more metropolitan area, we see the patients that come to the hospital. So our population is a little bit more, it's a little bit more broader and Macon at the Navicent Medical Legal Partnership as compared to our client population in the rural area down in Waycross, Georgia. Next slide, please. Develop a strategy to screen patients for legal needs that cannot be addressed by social workers. So basically, you want to develop a plan for how you're going to meet the needs of the clients that need your services under the medical legal partnership, whether you are in a healthcare center or in a hospital-based model. You need to decide, how will we see the clients? What will be our plan for addressing the folks that need to see our services? And so that will mean that you will need to talk with the folks that are your key players and come up with a strategy. Next slide, please. Define staffing arrangement. That means that once you have your plan, you're working on your plan, you want to decide how will your staff be housed at the facility. Will it be one full-time staff, two part-time staff, and if you're in a metropolitan area, possibly some pro bono staff members. Okay, next slide, please. And this is a biggie right here, the MOU. Once your plan is developed, once all the parties have agreed on moving forward, you want to develop an MOU that will contain all the terms and conditions of the medical legal partnership. Next slide, please. And then again, the staffing arrangement, we talked earlier about, how many staff you will have to support the project, but where will the staff be housed? In Macon, we have a staff member on site at the hospital, and the same thing with our project down in Waycross, Georgia. We have staff members that are on site. And so the good thing about having staff members on site is when doctors see patients with issues, they can quote unquote refer the patients right down the hall to the legal staff member. Next slide, please. Training health staff. This is really important. Once you establish the medical legal partnership and you have it functioning, up and running, so to speak, you want to make sure that you train the clinicians so that they will be able to recognize patients that they can refer down the hall, that they can recognize patients that have legal problems that the medical legal partnership can help. And so that's important. Make sure that training takes place once the medical legal partnership is up and running. In the early stages, you want to make sure that you train the health staff so that they will know what kind of cases can be helped by the legal services that will be provided. Next slide, please. And an arrangement for sharing information. This is really important also because, once you have your medical legal partnership up, you want to make sure that the partners, the key players, both groups, the hospital and the legal service provider, that they share information so that both parties can know whether the medical legal partnership is working. Both parties can know whether there's something called ROI, return on investment. It's good for hospitals to know that there are some benefits for doing a medical legal partnership. In many instances, return on investment, the ROI, it can allow for the hospital to recoup funding and expenses that they were not previously able to recoup from patients. But in many instances, the medical legal partnership staff member can help recoup some of those funding for the hospital. And number 10, last slide, long-term funding. This is really important because, again, stability, because once you have your project up and running and it's moving forward, you want to make sure that you discuss funding so that your project, so that it will be long-standing, so that it will continue for an indefinite period of time. Generally, when you establish a medical legal partnership, there's about a 2 to 3 year window where it's going to take time for the project to get established. It's going to take time for both partners to become abreast on the benefits, the pros and cons, and the issues. So during that 2 year window, you've got to make sure you have funding available because again, this project, it can provide tremendous help to many folks in need. And so with that being said, I want to conclude my presentation. I just want to highlight one important takeaway, and that's partnership, the big thing about medical legal partnerships, the terminology, it perfectly fits this project. You have a legal partner and you have a medical partner. They come together and they're working together in a holistic manner to help individuals that have legal issues and folks that have a next issue. I mean, legal issues and health issues. I'm sorry, thank you. So that's it for me. And at this point, we're going to turn things over to the next presenter, Rachel Henderson. She's up next. Thank you, everyone.
Thank you. My name is Rachel Henderson, and I am going to talk about navigating relationships with community partners and the benefits of a strong community presence. But basically, it's difficult to reach rural communities. How do you work in difficult to reach rural communities? Now, I must admit initially that I am a native of Waycross, Georgia, so I know what it's like to live in a rural community, and I think we have a slide coming up that shows you how far South Georgia. If you look toward the southeast, that's how far south Waycross is, closer to the Florida border than to Atlanta, and closest to Jacksonville and to the Golden Isles, St. Simon's Brunswick office. And the Brunswick office is the primary legal services office for the Medical Legal Partnership. One of the things I wanted to say is the interesting thing about doing community and working with community health care organizations, just like you have community policing, we need to be community lawyers. One of the things I decided out of law school is I wanted to be as close to my hometown as possible. And as I shared with someone initially, we worked to create the McKinney Medical Center. And that was a whole community effort. And it was not me, myself, that initiated that process. And I'm going to tell you that in a minute, but I want to let you know that our initial grant for a community healthcare center was denied because people could not understand, as Ira mentioned, how it could sustain itself in a small rural community. As not only sustained itself, it has thrived. And the medical legal partnership working, both of us have thrived as a result of that relationship. It started out, interestingly enough, by Georgia Legal Services health law specialist who was concerned about rural health. And she contacted the Morehouse School of Medicine Health Promotion Resource Center. She said, can we talk about funding? They in turn contacted a pastor named Arnold McKinney, and hence the name McKinney Medical Center, but he was a fellow at the National Council of Churches as a health law intern. And in addition to that, they contacted the Ware County Health Department. Georgia has health departments in all of its 159 counties. So that was the original group. Being a staff attorney at Georgia Legal Services, and I specialize in Social Security, SSI, health issues also, we went to the state, got the designation that you can see from the next slide. Who are our state partners? Our state partners was the State Office of Rural Health. It'll be interesting for all of you to check to see if you have similar organizations in your state office. And the state Medicaid agency, FQHCs, the State Office of Rural Health, and we had to work with the local community to get something called a federal designated rural underserved site. With that as an underpinning, the lawyers were able to get that all in place. We were able to use the data, and hence we have the McKinney Community Healthcare Center. So it started out as a collaborative partnership in a rural area. What's interesting about a community healthcare center, and it's good all of you are interested as participants today, is they have a mission that's very similar to the mission that Georgia Legal Services or legal services organizations have. And what we do is we worked hard to make sure when we approached Miss Ola Carter Smith that we talked about how we could use our mutual missions to form a very successful merger in terms of relationships, in terms of what Bethany referred to earlier as a holistic approach to providing healthcare access and legal access, how the two factors intermingle when you look at national health indicators to create an environment where clients are better. One of the barriers we discovered that we could use was transportation. So when Ms. Smith wrote the initial grant, she wrote in a transportation arm because we looked at access to anything in a rural community as being primary. Also, you can be a resource to the community in terms of the geographic location, because you can talk about the kinds of relationships to each entity within the community. You as an organization, legal services and other organization, and others will be involved in the process. I don't know if I'm supposed to answer questions now or later in the chat, because I did see an interesting question come up, and I'll try to integrate the answer into my presentation. And you have to, how do we reach marginalized communities with very little resources? And even though Georgia has the claim to being, and Ware County, where Waycross is located, geographically, we are the largest city in the largest county east of the Mississippi. So you could see that this area is a huge area to cover. But in addition to that, the Brunswick office is responsible for 17 counties, and some of them at least 100 miles or more away. So this community healthcare center with its transportation was something that we worked on, and we worked with the city to get rural transportation. One of the things somebody asked is about social workers. Yes, we also work with social workers. And as we were preparing our MOU initially, as Ira said, in 2022, Ms. Smith Carter realized that she did need social workers. So on site at the McKinney Center, they do have a certified social workers and 2 assistants. So they are there to advise, and they also refer, especially senior citizens, to us for panoply of things such as power of attorneys, advance directives. We do a lot of those kinds of cases, which Malik will talk about. So we received a call, and we've done training, as Mr. Foster said, for the American, what is it? The Licensed Clinical Social Workers Association. We've done trainings for that organization and show how all of that dovetails in creating a healthy community. And you can see for the demographics is much needed. One of the ways we also reach marginalized community, and we talked about the transportation barrier. We were able to work with the city and the county, and they wrote grants. And now in all of our rural counties, they have state funded grants to provide bus transportation. So when a person comes to the center, we can see them, and all the services can be provided at one site. We also made sure that we had and hired, she has staff members who are bilingual, who speak a number of languages. So, what are your resources? And you have to look for resources in unusual places. One of the resources is the faith community. As I indicated, the National Council of Churches was very active in pulling together all of these activities and providing access to locations so that, and health fairs and producing activities so that people could access the center. The local health departments, we don't think about those. They were very instrumental. They helped us with a lot of data about the types of people who live within the community, because we have serious problems with heart disease and cancer in rural Georgia. And with our young people, our suicide rate is extremely high. The other person that we work with are funeral homes, because funeral homes are also people who are very well known in the community, and it's something that you should look at. Go talk to the funeral home director. The funeral home directors has an association, and they work very closely with us. And for tools, we created flyers, and we ran those flyers to readability level. We did newspaper articles. The newspaper runs our information about the McKinney Center almost on a daily basis, because we involve them, and it's a community-based newspaper. We met with community-based organizations such as Family Connection. I don't know if you have those in other states, but in Georgia and all of the states, we have something about Family Connection, and they always look for resources, and they pull together all the agencies within a county, meet monthly, and talk about how we can share. What are the issues? How do we deal with the homeless issue? And then the community healthcare center has a mandate to work with the homeless, the mandate to work with veterans. And then they were able to get additional funding to cover some of the lead-based paint issues that we see in terms of older homes in rural areas. We did a grand opening with the Chamber of Commerce, so everybody is aware of the medical legal partnerships, and we made sure, and Malik will talk about this later, that we publicize it in terms of social media. In terms of social media, who do we target? Everyone in a small community, because everybody knows everybody. So we have banks and credit unions and sporting events and neighborhood grocery stores and laundromats. We literally went all over the county so that we can make sure that individuals were aware of aware of the existence of the program. As an aside, you can talk about what benefits everybody in the community. You look at trade and professional associations here, courts, but one thing we did not think about, and that's the private physicians. And so what we did is we talked to the private physicians, told them about the creation of the program. Then we approached the state Medicaid agency, and if you're an FQHC, an interesting thing to learn is once you have that designation, which we as lawyers were able to get as medically underserved, that means that the Medicare reimbursement rate increases for private attorneys. So it was private physicians. So it was a win-win thing. Everybody became invested in making sure this was a success, making sure that people knew about the availability of services. So you never know where your resources are going to come from, including CPAs who helped us do 501c3s, who helped us do some of the accounting things. People to see, you need to see everybody. A particular interest, and most people don't think about it, is we sat down and talked for a long time with the local chief of police, because he talked all about poverty and how much they see when they have to visit homes, and they were glad that someone was going to do something. And that tied us in also with mental health and how we work with those nonprofit mental health and state agencies. And the key constituents information is sharing. Everybody should know. Everybody should be trained. The staff can be trained, as Mr. Foster said, everybody, so they can build on one-to-one and a relationship, and we can help everybody improve their health status. So as I indicated, it's building a relationship is really time consuming. It's an awful lot of work, but you can do it. And both partners fully engaged can make a significant difference in the community. So rural communities operate a word of mouth. So if you have a successful case, we share that. The newspaper sometimes will pick up an article and talk about the referrals. We'll talk about the clients and how we help that elderly parent in any particular case. So we looked at local TV stations and presentations, but I think the best takeaway is to work hard at building up their relationships. Show that your mission is similar to everybody else. Talk about what a healthy community looks like. And one of the takeaways is that since we have a remote location, is training staff. I think Mr. Foster said that, train staff, because you can't do all the training, but they will tell their friends, their neighbors, and everybody else. And also benefit and highlight successes, because word of mouth is very important. But you can use all of the organizations we talked about, including client communities, sororities, fraternities. Everybody participates in the process in a rural community. I missed some of the chat questions.
We'll get to them again at the end, Rachel, but you actually did
Okay.
a great job of addressing some of those. So keep those questions coming in.
Thank
Thanks,
you.
Rachel.
Hi, good afternoon, everyone. My name is Tara McIntosh. I am an attorney with Georgia Legal Services. I work out of our Macon regional office, and I'm the MLP attorney for our hospital-based MLP. So next slide, please. So like Ira shared earlier, we are partnered with Atrium Health Navicent, and we started in 2016. Atrium Health is part of the larger health system, Advocate Health, which is the third largest nonprofit health system in the US. So we are just one small piece of this much larger health system, but even our hospital, our small piece is big, especially for Georgia standards. Our primary focus is the medical center in Macon, Georgia, which is a level 1 trauma center and one of the largest hospitals in Georgia. We primarily serve inpatient adults with their health issues and legal issues that come up while they're in the hospital, but we also do receive some referrals from the more rural hospitals that fall within our health system and outpatient adult care, especially if those outpatient adults are likely to be admitted to the hospital. We serve low-income adult people of every age and children, and then we serve some seniors regardless of income if there's a compelling reason that they would need services that it would be very difficult for an attorney to otherwise provide. So our primary goal for our MLP is to support low-income healthcare patients in navigating legal challenges that create barriers to achieving better health. This is the goal that we have in our MOU of what each partner is working towards for the MLP. And then, of course, there are secondary goals for both the legal partner and the medical partner that align with each partner's individual mission and goals. We maintain office at the medical partner's main hospital and at our law office, and I split time between the two. Each partner provides the technical support and office supplies and other such needs that you need for their physical space. We also sometimes have law students that intern with us, which is great. And when we have law students, they will also go in between both sites. We are 100% funded by our medical partner. We have been since we were created in 2016. And like Ira said, we were initially funded by foundation money, but have transitioned to become part of their annual operations budget. During our first MOU, we have 3-year MOUs. During our first MOU, we had a set amount that we were to receive. When we renewed our MOU later, we added in an annual cost of living increase into the grant amount, which we felt was a great move. Both partners were supportive, and we recommend that because it just makes sense that as people have cost of living increases, you want your grant to reflect that as well. Next slide, please. So we are located in Macon, Georgia, which is right in the middle of the state, and our primary focus is to serve residents of Central Georgia, and that's who these focus demographics are on. We end up serving patients or clients who live in South Georgia or just more general, like rural than Macon, because the more rural areas lack the complex medical care that some people need. But these are just based on our main Central Georgia area. We have a population of about 465,000. It's about 2/3 urban, 1/3 rural. 17.6% of our total area population lives below the federal poverty level. This is higher than the Georgia state average and the US average as a whole. And then if you just look at children ages 0 to 17, 24% of children living in our area live below the federal poverty level. So we have a huge client base within our region. For social determinants of health in our area, 11.3% of the population age 25 and older does not have a high school education. 31% of the people reported that they sometimes, usually, or always worry about having enough money to pay their rent or mortgage within the past year. 16.3% have lived in unhealthy or unsafe housing conditions within the past year, and 13.4% went without electricity, water, or heating in their home. And then just overall, 35% of the residents are food insecure or have low food access. So as you can see, there's a huge need for legal services and for this medical legal partnership in our area based on the federal poverty level and the social determinants of health that we're facing. And we are very fortunate that our medical partner was aware of these challenges and really wanted and supported our partnership from the beginning. So at our Macon MLP, at our hospital-based MLP, we've been operating for 7 full years. During the first 7 years, we received over 1,000 referrals. From those 1,000 referrals, we opened about 689 cases, representing 542 different patient clients. We do follow the iHelp model, but just based on the referrals that we receive, our primary case types have been power of attorney documents. Like Rachel was saying, they get a lot of those as well. Sometimes we get them just because people want or need a financial power of attorney or advance directive when they're in the hospital. I would say a majority of the time there's an underlying reason that they need it immediately while they're in the hospital. Sometimes they're trying to qualify for nursing home Medicaid, and I feel like this is probably an issue everywhere. If someone, especially among seniors, that they don't do online banking, they may not even have a debit card. And so when they're trying to get that Medicaid approval and they need copies of bank statements and things along those lines, they need an actual power of attorney so that someone can go to their bank and get those statements and talk to their employer, retirement company, or whoever and get whatever's needed to get that Medicaid approval, because they don't have the online accounts and support to do it themselves, or even like guide someone to do it on the computer. So power of attorney documents to get someone Medicaid, to pay someone's bills because they've been in the hospital for weeks or months and they don't want to lose their home or electricity or whatever else when they do get discharged. Sometimes people are living in like an upper level apartment, but because of their medical condition or surgery or whatever has happened, they can't access their current apartment now, and they need that power of attorney so their agent can go talk to their landlord and say, hey, you need to accommodate them in like an apartment that they can access easily. So, and then all of those lead to the patient getting the services they need and hopefully getting discharged and having like stable housing and support to go to after. We do a lot of Medicaid cases, other public benefits, kinship care, both if the child is the patient and their caretaker is not their like legal guardian, we help with that. We get a lot of palliative care cases where someone has minor children, they're at the end of their life, and they just want to go ahead and make those arrangements for their minor children so that they can accept their comfort care and know that their children are taken care of. And then some family law. Someone asked in the chat earlier about probate cases. The main types of probate cases we would take would be if a patient, particularly a senior or disabled patient, they're living in a home that belonged to their mom or dad, but they never probated their mom or dad's estate, so the home isn't really in the patient or client's name. And normally there's a reason now that they have to probate. Sometimes they've been making the mortgage payments on it, but the mortgage company's like, nope, you're not actually the owner of this house. You need to be the owner of this house, or you're gonna not be able to make mortgage payments and then have a bigger issue. Sometimes they're facing a tax issue. A lot of times they've connected with a resource that's going to help them replace their roof or do other like major repairs on the home for them, but the house has to be in their name for them to do that. So we would probate their parents' estate to put the house in the client's name so that they can then have that housing stability and be able to address whatever the secondary issue is going on. We've also done some probate for patients' families if the patient passed away and they have minor children and we want to secure that stable housing for the minor children, or their spouse or loved one would just have a really hard time navigating the system for some reason. And then outside of like the classic probate, again, we would do like minor guardianships and things that take place in the probate court. Our initial focus was on getting our name out there and just, refer. We'll sort through everything. So as you can see, just over half of our referrals actually resulted in us accepting a case for a client, but we did always try to connect them with a resource or self-help materials or something along those lines, because we just wanted people to think of us and call us and establish that good relationship. Now that we've been established a while, we do work more on trying to get more significant referrals for case types that really like impact their health and that are cases that we can accept. Next slide. So being funded by our medical partner increases our focus on serving the medical partner and making them happy, along with our usual focuses of serving client needs and working towards the goals and mission of the legal partner. We want to show that there is a financial benefit to the medical partner whenever we can. We're not going to be making them money, of course, but if there's some sort of cost savings or resource that we can be for the hospital staff, we definitely want to show that. And so the reasons for making a referral to us normally have to do with trying to shorten the length of stay for a patient, reduce readmissions, obtain a payer source, which is really obtaining insurance for someone. Again, assist palliative patients, which is like a huge area of just providing good community care and comfort care for people, and then addressing current community issues. Luckily, all of these relate to the case types that we already want to handle and do handle. So if we're able to get someone nursing home Medicaid and get them discharged to a nursing home, that's going to shorten their length of stay. If we can help with a housing issue, that's normally going to reduce readmissions. Getting someone Medicaid is getting them a payer source. We already talked about palliative patient care. And then current community issues just depends on the time. For a while, we had a very big issue where nursing homes were just kind of dumping residents at the hospital because they didn't want to go through the proper nursing home discharge process, which is extremely harmful to the resident and just a crappy thing to do all around. So we really worked hard on like stopping that and addressing that for a while. There was an issue where someone was going around to places that low-income people would frequent, like food banks and homeless shelters and things along those lines, and trying to convince them to sign up for Medicare Advantage plans when it really would not benefit the group that they were going after. So we worked on that together for a while. Next slide. And a story that I think really encompasses all of this is that we had an elderly patient who received an emergency discharge from a nursing home after an altercation with another resident. It's up in the air whose fault it really was, but regardless, they sent her to the hospital, refused to accept her back. And she ended up living at the hospital for over a year while the medical team figured out what her needs were, and they ended up applying for her Medicaid waiver program on her behalf. She really didn't need a nursing home level of care, but they couldn't discharge her just for her own care. She definitely needed some sort of community support services. So she ended up being denied the Medicaid waiver program, and we were asked to appeal the denial. Everything that could have gone wrong did go wrong. They sent the denial to an address that they knew she was clearly not living at. Whoever did the assessment said she didn't qualify for services, even though they were services that she's received in the past, and her diagnosis weren't conditions that would get better with time. So we appealed, we fought and fought and fought, and finally she was approved for the Medicaid waiver program. And we worked with her hospital staff to find her a like supported living environment where she lived with other people with similar conditions and received those in-home support services. And she was already SSI and Medicaid approved. So the benefit to her was huge because she finally got to leave the hospital, got those in-home services, you know, free of charge, covered by Medicaid. And then by getting her discharged from the hospital, it saved the hospital hundreds of thousands of dollars that they were losing by having this person take up a Medicaid bed for, you know, over a year that could have been used for another patient or a patient with a higher payer source. And so their return on investment was well over $500,000 by the time she was able to be discharged and be on her own. And she hasn't been back, thankfully.
Okay. So hello, everybody. My name is Malik Hines, and I am a new staff attorney with Georgia Legal Services Program's Brunswick office. And I also am the medical legal partnership attorney for the McKinney Medical Center, which is our community-based healthcare center model of medical legal partnerships. Next slide, please. So really what I'm going to talk about today is what my day-to-day looks like. But first, I'll be remiss without talking about our partner. So our medical partner is the McKinney Medical Center. And when I say the McKinney Medical Center, that encompasses all of their locations in this area, including but not limited to their offices in Folkston, Alma, Georgia, Nahunta, Georgia, and of course the office that I am in now, which is in Waycross, Georgia. They also partner with different entities, and they also in their umbrella have the Nelson Green Senior Citizen Center as well. So our medical partner has quite a lot of offices and quite a lot of presence in the area that we serve. Next slide, please. So boom. So first, we have to talk about what our understanding is and thus how we collaborate with our understanding. So the McKinney Medical Center and Georgia Legal Services Program both recognize that barriers to improving health outcomes for low-income individuals often stretch beyond what can be reached through just medical assessment and treatment. And I think that's something we can all agree on, is just because a lot of the problems that our clients and the people that we help face are well before they even get to the actual doctor's office. A lot of times we see that their lack of access to healthcare and other public benefits rather makes it so they're not able to even pay for the medical treatments that they need. And that is what we see a lot of. And therefore, the McKinney Medical Center and Georgia Legal Services Program both seek to establish a collaboration that will help low-income individuals in the McKinney Medical Center's patient community access legal advice and representation to address the social and environmental factors that negatively affect their well-being. Next slide, please. So how do we work together? And I think generally the first thing is office space. So the McKinney Medical Center paid for everything that you see in this picture of my office that I'm currently in right now. They gave us a dedicated space, a phone, another computer screen, a printer, as well as other resources that I need. So that is something that when you do your medical partnerships, just advocating for the attorneys or other staff that you'll have working at these locations, just because a lot of times we may see that they are not as equipped to house people outside of their own staff. And that is something we're seeing necessarily in the Folkston Center. So we are hopeful in the future, So we are hopeful in the future that the Folkston Center, which one of our paralegals at Georgia Legal Services Program currently works at, will have a dedicated space for her in the future. And we're doing that advocacy work every day. Next slide, please. So one of the main things is referrals and help with intake, and that is a lot of what our relationship is. So generally what my day looks like when I'm working my medical legal partnership position is 2 days out of the week, I come to this office in Waycross, Georgia, which is about an hour and some change away from where I live in Brunswick, which is closer to our main office. So with the permission of the clients that the physicians see at the McKinney Medical Center, they will refer them to us if they get a sense that there's a legal issue that is affecting their patient. Now, I say with their permission because, of course, when you are working with the medical legal partnerships, as well as our own attorney-client privilege, the different things about our clients, have to be kept a secret, or at least our connection with them cannot lead to any of this important information being leaked or otherwise getting out. So the McKinney Medical Center staff utilizes a uniform referral and confidentiality system of documents that makes pre-screening and thus the intake a lot easier, because those intake and uniform referral documents that they send to us will have not only the client's name and their potential issue, but also their birthdays, a number to reach them, and I mean, really their entire medical history if the problem that we're seeking to help them with rather involves, determination of disability or some sort like that. Next slide, please. So once again, I think the main thing is that as you work together, it's not just necessarily me being in here and doing my own separate intake, but it is us working together with the resources that our partners have. So like Tara was saying, how she utilizes a lot of the hospital's resources, I also utilize some of the McKinney Medical Center's resources. So for instance, in terms of healthcare, the McKinney Medical Center has their own sort of privatized healthcare called the sliding scale fee, where people who are not able to qualify for such things as like, regular Medicare and Medicaid can still get medical services by paying a sort of subsidized premium. So that is something that if we're working with someone for disability or Medicare or Medicaid, and for whatever reason, we're not able to match them with the plan, or if the Affordable Care Act marketplace is not something that is working for them, they can still have an option to getting their, medical needs done via the sliding scale, which is something specific to the McKinney Medical Center. But I am sure other entities have, some sort of clone of that. Of course, the McKinney Medical Center also has their own dedicated Affordable Care Act navigator. This navigator, he also coordinates outreach efforts with us. And in fact, we are now collaborating once everybody's a little less busy to go to the Kingsland location for the McKinney Medical Centers and do some tabling and outreach just so we can reach people in that area with a little more ease. Just because, as you'll learn in these rural communities, there's a lot of land in between different locations, and transportation is not something that is universally accessible to everyone since there's no public transportation. And as we all know, times are getting a little harder. So even owning a car is not something that is as automatic in the lives of everyone that we see. Next slide, please. So who we serve is just as important as how we do it. Next slide, please. So the patients of the McKinney Medical Center and the community large are who we serve. And what that means is most of what the people that I see are not actually direct patients of the McKinney Medical Center. The McKinney Medical Center has a large word of mouth presence in this community. So a lot of people already know that I'm here and that me and Miss Rachel are here 2 days out of the week. And that is done just because we are now published in the newspaper. And that was done, not by us, but by the medical legal partner and the people who see the good in what we do. So now our ads run in the newspaper. So in the Waycross Journal Herald, for instance, and the Charlton County Herald, there's a running ad that tells people that they can come to the McKinney Center on Tuesdays and Thursdays and come see me or Ms. Gail Henderson. And as well as they have our contact information up there as well. But of course, we also see new or current patients at the McKinney Medical Centers. A lot of times, if someone is, coming here for their appointment, but an issue arises with their healthcare and they're not able to pay it, they'll send them right here to our office. So either I can try to help them with some sort of Medicare, Medicaid issue, or if I'm not able to, then the sliding scale or the Affordable Care Act navigator person can also do that. So we have a wide, range of resources for everybody. And can I get the next slide, please? Thank you. So the specifics of what we do. So of course, like Mr. Ira explained, Georgia Legal Services Program does free legal representation for people, but we are in the civil realm. So we do not handle criminal cases where the patient wants to, cases where the patient or the client wants to sue another person for money, AKA fee generating cases, or cases, of course, where the patient already has retained counsel. Oh, next slide, please. But some of the issues that we regularly see are as follows. So I see a lot of domestic violence related divorces and TPOs, just because, the history of violence in all communities, but generally in rural communities, we see a lot of those. estate planning issues. Generally, like Tara was saying, a lot of people want power of attorneys for a lot of different reasons, advanced directives for healthcare, if they feel like they want to appoint someone to have the authority to make those decisions for them. And of course, we do a lot of last wills and testaments as well. Securing and maintaining public benefits is obviously the bulk of what we do, just because we are at a medical center. So of course, a lot of those issues are going to be involved with people's access to healthcare. Housing issues and such as dispossessories are a big thing that we're seeing now. Really, we see those, at the turn of the month. Consumer issues and elder manipulation. And I do have one quick story I would like to tell about that. So this story is how, even though we didn't necessarily have to represent this person, our presence in this community does a good in the community. So one of our seniors, she recently had bought one of the standing bathtubs that, fills up so our senior is able to stand in it and take a bathtub. It was installed and everything, but when she tried to take her very first bath in the newly installed tub, it leaked and the ceiling under the tub fell off completely on the ground. She wasn't a person who was able to litigate this herself, obviously. So she came to us just to kind of get someone behind her in her corner. And even though we never necessarily had to do anything with the company that installed the bathtub, her telling them that she had spoken to us, put the fire under them to fix the problem themselves. And they ended up replacing the tub and fixing it 100% free for her. We also see, of course, guardianships that come up. And I think one of the questions was about how to discern whether if something is something that a social worker should handle or something an attorney or legal representative should handle. And I think that goes more to what your job as an attorney and what your firm accepts and denies. A lot of what we do isn't necessarily legal representation as if I'm representing someone in court. And a lot of it could be construed to be more on the social work end, because we are helping people sign up for different public benefits, or really just giving them information to help better their lives. So in that sense, we are social servants, and we just happen to be attorneys. So the roles that we do will bleed into the roles that other people do, but that's where the collaboration comes in, because we don't have to do everything ourselves, since there are a lot of people and a lot of entities and organizations that have the mission of helping people. Next slide, please. Okay, and my last slide is about the data. So, Mr. Ira spoke more about acquiring grants and funding, but from our perspective as the attorneys who work these sites, the data is important just to show that we're working, that the work helps. And because when we show that we're working it, that the work helps, there's more opportunity for funding, and thus there's more opportunity for us to help more people. So from May of 2022, when this medical legal partnership started, to now, we have accepted for legal representation 113 people, and we have been unable to serve around 123 people. But nonetheless, even when we were not able to serve them, we gave them a referral, or we sent them to another GLSP program. A lot of times people will come in and say, hey, I'm moving to Savannah. And I tell them, well, hey, I will refer you to the Savannah office. So, we see a lot of that. And then we do see some cases where, someone comes in because the medical centers have such word of mouth. People are coming in from the community for any type of legal issue that they may have. So we've had people who come in who, based off our grants for Georgia Legal Service Program, we don't even do those types of cases. I've had people come in for criminal cases and, DUIs and all sorts of things that we just don't handle based off of our granting and funding and such. But we still nonetheless sent them to a resource that could help them. And at the very least, we do what is called a counsel and advise letter to give people the tools and knowledge to at least attempt and start to help themselves. All right, so that is it for me. Any questions? I think Bethany will help us facilitate the question and answering.
Yeah, that's right. Thanks, Malik. Thanks, Tara. Thanks, Rachel. And thank you, Ira. We definitely have questions that came in through the chat. I was also trying to do our best here to reshare some of the tips and emphasize some points that you all were making along the way. So I want to go to the Q&A, and thank you all again for also attempting to answer some of the questions. One of the questions that came in the Q&A, are you all at Georgia Legal Services Program willing to share any sample MOU documents with attendees? If the answer is yes, the National Center is happy to help disseminate some of that. So I want to pose that to Ira. That one's a pretty simple question that folks often need some help with. Are you willing to share an MOU sample with attendees today?
Yes, yes, I have several samples that I can share, samples that I used to help develop the Macon project. I have samples that I used to help develop the McKinney project. So I have samples of both the hospital-based MOU and the medical center MOU. I'll be happy to share those samples.
Thanks so much. Thanks so much. So we'll make sure that all attendees today, we'll clean that up so that it's shareable and disseminate that in a follow-up. So stay tuned. We'll be happy to share samples. Next question that came in, and I'll pose this to the group because Malik just highlighted some of this. What is the best data to highlight to show ROI for long-term funding? Malik, what you shared on the screen, it was what you're collecting and gathering, and you started to talk about some of this is why you gather it, to document what you're doing, how well it's working, and so that you can make the case for future funding. Just want to see if others can chime in, because that, what you shared, Malik, is for the health center. In addition to both you and Tara sharing storytelling. So any tips for the audience on the best types of data to highlight to document ROI?
For the hospital, similar to Malik, we do a quarterly report that we send to both partners that shows how many referrals we got each quarter and what happened with each referral. So if we connected them with a community resource, or if we even got a call that was really meant for like a different department at the hospital, like that's still a service that we're providing to like help connect people. So we show a breakdown of how many referrals came in and what happened with those, how many cases were open in those case types. And then we feature around 3 or 4 good stories. And the good stories, we try to, if there is a financial benefit to the hospital, like what we did really impacted how long someone was there or the chances that they're going to be readmitted, we absolutely focus on that. Otherwise, we try to share really compelling stories to show that even if it's not a financial benefit to them, that it's like really good, important work that they can use when they're applying for their own, whatever, or building, positive support within the community. And then once a year, we do an annual report. And in that annual report, we'll put finances that Georgia Legal Services tracks on, like the Medicaid benefit or whatever the financial benefit to the client is. And we show that. And then the hospital will sometimes use that to figure out like if there was a benefit to them as well. But I think we, like everyone else, are still constantly trying to figure out how to properly show like what the financial benefit to the medical partner is, and it's really difficult to grasp.
Mm-hmm.
And I want to chime in also. And when we reference return on investment, I want the audience to be clear that this is not funding that we give directly to the hospital. This is basically a way of showing the hospital benefits that they receive as a result of the services that we provide. Like, for example, the good case story that Tara gave, and the good case story that Malik gave. Those are outcomes where the hospital benefited by us providing services to those clients that made it so that those clients did not have to be at the hospital for a longer or a more extended stay.
Bethany, I'd like to just chime in with one thing. We were actually told where we are housed, where Malik is sitting, is right down the hall from the chief financial officer for McKinney. And what's interesting is she has shared with us that both there's an increase in the number of patients actually coming through the center. And second, the fact that we win all the Medicaid denials, that means they are paid for the services they provide. So since she is an accountant, she really does track that kind of information, and it has the financial benefits as a result of the partnership. And that really was the impetus behind her putting her, one of the impetus at least behind her putting us into her annual operating budget.
And if folks can imagine, I'm glad you all mentioned it, securing coverage for someone or reversing a denial on a claim for that individual who was covered. It's not just beneficial to that individual patient and then the provider, but also economic benefits to the community, because you're really relieving what could be a barrier to
Yes.
other just
Yes.
expenditures that a person might have to, pay in life, right? Rent, transportation. As noted, these are really rural populations that are being served in these areas. And so folks need every penny they can retain to be able to meet their basic needs. Glad you all brought that up. Another question that came in is about really what every MLP faces, whether they are fully implemented or still trying to work out kinks along the way for an established MLP, and that's information sharing. So the question that came in is, are there any ethics or conflicts issues that arise between serving a client and the hospital when there are those benefits? So this is a two-part question. One, as it relates to the information sharing, and that's sometimes where the ethics questions come up. But then also, as we are talking about ROI, how are you overcoming any ethical or potential conflicts of interest?
I don't think there are conflicts of interest regarding us helping clients when they're one, they qualify for our services, they're low income, and then we basically help them with services that we would normally help any client obtain, except for the client may be in a medical facility. I don't see any ethical or conflicts. And then also, again, with our MOU and our screening tools that we have in place, we look at conflict interest. But if we were to see that there could be some potential conflict interests, we could easily amend our MOUs and easily redesign our screening tools so that we could cover conflict interest. So even if there is an issue, there are ways to easily correct the issues. One, like I said, by amending, our screening tools and amending our MOUs.
Great, thank you. And Tara?
So yes, it hasn't really come up that much, but like Ira said, part of our MOU is that we would never take a case against the hospital, and normally the patient's goals and the hospital's goals align, but we're always very clear that our client is the patient and we're only going to do what the patient wants us to do, and like that's who we're serving. So every time I do like a presentation training with a hospital group or talk with someone, I'm always like, I'm serving the patient and the patient's needs and wants. And so most of the time it's fine. Sometimes the hospital will make the referral and they'll be like, the patient really needs this, or they really need to do this. And then you talk to the patient and they're like, no, absolutely not. So I would say like, okay, is it okay if I like tell the person who made the referral, that we discussed this and this is what you decided? 100% of the time they say yes. So then I just go back to the person and I'm like, look, that's not what they want to do. I can't make them do it. But, if they change their mind or, if there's another development, call me back. And that's kind of where it ends.
I think it's key. Malika, I was just going to actually ask you to chime in because you had the word permission on your presentation.
Oh yeah. So I think one thing I just wanted to kind of draw a difference would be where when I heard the question initially, I was thinking more, well, hospitals usually are for profit in the sense that they are organizations, kind of. I don't know if the hospital Tara works is in, but that was one of the things I thought a conflict may come up. But for the McKinney Center, they're nonprofit in the sense that they don't have a money-making mission first. So there would really be no issue in terms of, getting them access to healthcare versus, the McKinney Center maybe having some sort of want or agenda to get them on some sort of more privatized or their own sliding scale. So that's not really a thing. From all that we've seen in terms of conflicts and everything, there haven't really been any because our missions align with the hospitals and medical centers we work with. So there aren't really any issues that come up in terms of representation because like Tara said, they'll never represent someone against the hospital, and likewise for us, I assume.
Yeah. And you're working that out, as Ira said, in your MOU to attempt to overcome or avoid that before it comes up. It's great question.
And one additional point I also want to mention is with our partnerships, with both of them, we have in the MOUs that there will be regular update meetings between the the partners that we will have regular meetings to review issues, to review, you know, how the MOU is working. And so again, with those regular update meetings, if we do see there's some potential conflict or ethical issues, again, we will correct those during those regular meetings that we have.
Ira, building on that, there was a question I just wanted to tease out a little bit more about how to better understand the role of social workers versus attorneys. I believe Malik may have attempted to answer some of this, but you just mentioned case management meetings, and I know Rachel really emphasized the need for trainings as well. So can you all share a little bit for the audience here what your MLP trainings or case management meetings look like?
Well, oh, I'm sorry, go ahead, Malik.
Okay, well, I was gonna start. I think as a newer attorney, I think one of the main things is because medical legal partnerships generally work with public benefits. That if I could go back in time, that would be something I would have looked at more in law school versus, you know, law school kind of only focuses on passing the bar and some of the more concrete portions of the law versus, you know, you can take an elective for something like taxes or something like that. But the training perspective has just been, you know, me being taught about Medicare and other issues that I don't know, supplemented with, you know, being educated about the purposes of the medical legal partnerships and my role in it. So, you know, generally it's, you know, seminars or PLIs, or really just sitting in the office with, you know, Attorney Henderson and just going over, here's SSDI, here's SSI type of things. When we've had meetings before with our, you know, partner, with Ms. Olaf for the medical legal partnership, and that was really just a check-in about where we are with the data and what we may need to, you know, better work and everything. So a lot of the meetings are just, you know, check-ins and everything like that. And then on our attorney side, we do the training of, you know, me and Tara, I guess, in terms of the substantives that we need to do in terms of representing our clients fully.
Mm-hmm.
And I want to share with the group that back in March, the last weekend in March, Georgia Legal Services Program, we had our board meeting, our annual board meeting in Waycross, Georgia. And at the board meeting, we invited the director for the Medical Legal Partnership, Ms. Smith Carter, and her staff. And along with all of our board members, we had our staff members that work at the McKinney Center to give an update to the board about the work that we're doing with the Medical Legal Partnership. The board meeting, it was well received. As a matter of fact, several of our board meetings, our board members mentioned that board meeting was one of the best board meetings that they had ever attended. And the fact that they mentioned that was that we took them in the field where our Medical Legal Partnership was located, and we let them experience firsthand groundbreaking work that we were doing.
Let me quickly add, one of the things we did extensive training. We have a Medicaid person, a specialist attorney with Georgia Legal Services. She came on and she did they did a training for their staff meeting, because they meet Wednesday mornings. She did an hour and a half on and provided an excellent PowerPoint. And the staff will still call me and say, "Oh, I didn't know about this program. How can we work better with children? How can we work with Medicaid waiver programs? How can we do this?" The other thing we did, because most people don't realize they have a defense, and Malik brought this up, and this was really good, is they talked them, there are answers in dispossessories. You can answer, there are defenses. So we had a housing law attorney come on and talk an hour and a half about that and left them excellent materials. Malik is right. We did public benefits. We actually did a session on wills and probate. We did all the things we did. We did in-depth training, left them with substantive materials. The doctors at the site really loved that, because we talked about retirement and the benefits, and we talked about SSI. And so we did that, and that was at our suggestion that we do in-depth training. So one of the things, if we ever go away, you still have people who are knowledgeable. So you leave something in a rural county that is a resource, and that knowledge resource is going to be long-term invaluable.
And two things I want to mention also is with our McKinney Medical Legal Partnerships, two things, audience, I want you to get is that facility is in a legal desert. It's located in an area where there's a shortage of attorneys, and then also it's located in a medically underserved area, an area where there's a shortage of medical resources. So that that facility, that partnership, it's invaluable. It serves a great need in two areas.
Agreed. So we are right at time. I have asked in the chat if the Georgia Legal Services Program team, Ira Foster, Rachel Henderson, Malik Hines, and Tara McIntosh, can share with folks how people can reach out to ask more questions, because there's so much more that people want to know. Do you have a position overseas the MLPs, right? The information sharing, people really, really, really would love to continue learning more. We know that we will be sharing some sample MOUs for the audience, so that they have something else to take away that's concrete and can probably use as a template to build their MLP. But we are in fact at time, so we'll be following up. I want to sincerely thank not just the audience for continuing to participate in this webinar series, but also our Georgia Legal Services Program team. I'm actually very privileged and honored to finally have this team on one of our national audience webinars. I'm actually presenting from the state of Georgia right now. So it's great to be amongst them today. So thank you, Ira, Rachel, Malik, and Tara, for presenting along with and on behalf of your healthcare partners. To everyone in the audience who tuned in, again, this is an example of medical legal partnership, practice, implementation, and planning in action. The Georgia Legal Services team presented on a hospital-based MLP and a health center-based MLP. If you have some really technical questions that aren't addressed in the Health Center MLP toolkit, or we couldn't get to one of the earlier didactic training, if you are particularly interested in that FQHC or Health Center model, the Bureau of Primary Healthcare, or HRSA, is receiving questions. So if you want to know more about the funding, some of the mechanics, and you're an FQHC, work with your project officer, but also use their BitBit contact form to ask technical questions. We have more coming up in this series. We're bringing on NILAG, so the New York based team from Legal Health. They work with New York City Health and Hospitals to begin to address that next question. How do you really leverage the EHR, or the electronic health or medical record, to share information, whether it's from the referrals or information back about your work? So they'll be on next week to talk about how their MLP is finally in the EMR and what success they've gained with New York City Health and Hospitals on the Epic-based EMR. On June 6th and June 13th, you'll be hearing from NCMLP's former communications director, Kate Marple, who will be talking more about that MLP training, right? So don't forget, it's not just individual legal services. MLPs also, as Rachel mentioned, really enrich and expand and enhance the capacity of the healthcare teams by conducting training for the healthcare workforce. And then how do you ditch the pitch, right? So that you can continue to be a sustainable medical legal partnership. So that's how we're going to talk about sustainability. It's really about messaging that Kate Marple will come to talk about. And then there's even more coming up later in the month of June. So sign up for the MLP update. Also go to our website to make sure you can keep track of what's coming up. We'll have Philadelphia Legal Assistants joining us later in the month of June. And then in a few months, we'll come back to talk about ethics. That's where Keegan Warren and Jay Sicklick will be presenting on those more ethical questions related to information sharing. I'm going to do a deep dive. So again, I want to thank you all for joining us. Sign up for the upcoming webinar, and definitely check out the upcoming resources that we have pertaining to those questions on data collection and performance measurement to drive sustainability and scalability. And then another thank you for everyone for joining us. We do want to know how we did. So take our survey. We greatly appreciate your feedback. Again, Georgia Legal Services Program team, thank you so much for presenting on today's webinar, and we'll see everyone soon again. Thanks, everyone. Have a great afternoon.
Thank you. Bye. Have a good day, everyone.